Hi, everyone. My name is Mia. Hi, my name is Mia McDonald. I use she, her pronouns, and I'm here today to share my experience as a frontline healthcare worker during the COVID-19 pandemic. I'm an emergency medicine physician assistant in the state of North Carolina. To become a PA, I completed a master's level degree of education and passed the national certification exam. As a PA, I diagnose illness, develop and manage treatment plans, and prescribe medications. In the ER, I provide medical care to patients for low acuity complaints like ankle sprains, as well as high acuity and complex complaints such as sepsis, strokes, and heart attacks. And since the end of March, I have worn an N95 respirator, a surgical droplet mask, a surgical cap, and a face shield for the entirety of my shift, anywhere from 9 to 11 hours at a time. Before we touch on COVID, I want to take a moment to talk about how the emergency department functions. Despite what primetime television may have led you to believe, a world-class plastic surgeon and a cardiothoracic surgeon will not be out in an ambulance bay in plastic gowns to greet an ambulance and take you directly to surgery before you've had any labs or imaging. Surgeons and other specialists must be consulted by ER clinicians before they show up and evaluate a patient. Also, contrary to popular belief, most of our days in the ER are not consumed by steamy hookups and supply closets. Another misconception is how patients actually get admitted to the hospital. Almost every patient who is admitted must come through the ER and be evaluated. In 2019, the hospital system where I'm employed had more than 212,000 patient encounters amongst the 4 ERs that my group staffs. The ER at our flagship hospital is actually one of the busiest ERs on the entire East Coast of the United States. And I want to emphasize that because that means that every person that needs admission comes through the ER. That includes all of our patients with COVID-19 that ultimately get admitted to the hospital. Since late last December, I remember reading about an unexplained pneumonia outbreak in China. And I remember making a mental note in the back of my head, but I didn't give it much thought until a few weeks later when reports started to hit the media about the first death from an unknown virus. And then just weeks later, there were cases popping up in Japan and Thailand and South Korea. And then the very next day, the first case in the United States was confirmed in Washington state. I think that it's important to note that during all of this is occurring during influenza season in the US. So just like most businesses have a busy season, all of our highest volume days in the ER occur during flu season. With high volumes come greater number of sicker patients who will ultimately require admission. The hospital will fill up every available bed, but there are still patients that are coming that are sick, that are ultimately going to be admitted. So where do they go? They get admitted, but ultimately stay in a room in the ER until a bed in the hospital on one of the floors frees up. And we have a special term for this in medicine. It's called boarding. And when patients board in the ER, we can't turn over our rooms to see new patients. So the waiting room just backs up and backs up. And this was what was happening around the time that we started to hear reports of COVID, around the time that the first case was diagnosed in the United States. And let's get back to COVID for just a second. At this point, actually, it's still an unnamed virus, but cases started popping up in many countries. A cruise ship was quarantined with more than 600 cases on board, and we started hearing about how the Italian healthcare system was overwhelmed by cases. They were running out of beds. They were running out of ventilators. I started seeing pictures of the vacant streets in Italy due to the lockdown. And I remember thinking, will that happen here? Could we even make something like that happen in the United States? A lockdown? It didn't even seem feasible at the time. And then guidelines were issued by the Italian medical associations as supplies in their country started to dwindle, including ventilators. And as these dwindled, the guidelines helped healthcare workers to make decisions on who would ultimately receive treatment, like a ventilator, and who would not. And a lot of it came down to the patients with the highest likelihood of survival. And as I look back now, I don't remember if I felt scared or if I felt angry first. I know I was angry about the fact that we all took an oath to do no harm. And then you have to make these decisions. And I was scared that I was going to have to make these decisions for our patients about who lives and who dies. I'm scared that we don't have enough resources to save everyone, as I was reading these headlines and reflecting back several months ago. And then I was scared for myself and for the people around me that I love. I have a lot of high-risk family members, and I was worried that COVID-19 would be a reason that they would no longer be with us. The cases in our country seemed to balloon overnight. At this point, still, we had no cases in the entire state of North Carolina. It was just work as usual. I work overnights, and working overnights means that I consume media typically only in the evening. My shift starts at 10 p.m. and in theory should end at 7 a.m. And I'm fortunate to have this kind of schedule to spend the evenings with my partner. I saw one of the first 5 officially diagnosed cases of COVID-19 in our hospital system. It was one of my first shifts back to work after being off for a few days. During that time, there was actually a flurry of emails coming in from both hospital and the ER leadership with policies on what PPE to wear and which patients to wear it with and what to do about testing for COVID-19, because testing was very, very scarce at this time. Early on, we were required to call the on-call infectious disease clinician anytime that we had a patient that came in that may require testing for COVID-19. In addition to calling infectious disease, we were also required to send a 2-page form that needed to be completed by the patient called a person under investigation, or a PUI, to the State Department of Health. I'm reading through these policies and my hands are wringing wet as I'm getting gowned up. I already knew the patient was positive. There were too many risk factors: recent travel to a country with a number of cases, fever, shortness of breath. And I remember thinking, what am I going to do about the person under investigation form? I have to take it in the room with me, and I have to take a pen with me. I have a disposable stethoscope, so I don't have to worry about that. But if I take the paper in the room, I can't sanitize it because it needs to be faxed. And what about this pen? Do I need to just throw my pen away? What if I use the pen and then I touch my face and somehow there's enough virus particle on the pen to contract coronavirus? And all of these thoughts are going through my head. And this was only the very first patient encounter. And it was then that my partner and I started putting together a plan for how I would decontaminate after every shift to make sure I didn't bring the virus home. With all of this going on, we also decided it was time that we update our will and power of attorney just to ensure that everything was up to date, just in case. This has been a long haul. The days have turned into weeks, and the weeks have turned into months of wearing PPE for more hours a day than not. Technically, the hospital policy says wear a mask and a face shield when you're in patient care areas. Well, I'm always in a patient care area. Our workstation's right in the middle of the ER. Now that COVID-19 is community spread, the bigger concern for our team is that we're going to contract it from one another. We do our best to social distance in our workrooms, but they weren't designed to have people sitting 6 feet apart. So I wear my mask and my shield in there too, which makes it really challenging to do things like eat and drink and make sure that you're staying hydrated. Most of the time, I just don't eat or drink the entire time that I'm on shift. I started having to schedule how many glasses of water I drink at home prior to my shift to avoid dry, cracked lips and feeling dehydrated after a string of shifts. I just wanted to say thank you for allowing me to present this honest view of what COVID-19 has been like for frontline healthcare workers. No makeup and all, because this is what I look like on my shifts day in and day out. I've got dark circles that I didn't used to have under my eyes from lack of sleep, constantly exhausted from wearing a mask all day and breathing in my own CO2. I've tried to find ways to put a bandage on my nose that doesn't compromise the integrity of my N95, because I ended up getting blisters and the skin on my nose was rubbed raw. And now, as I reflect on the last few months, when we first thought that this was a sprint and not a marathon, we thought that when the weather warmed up that the virus would go away, just like the flu. It's hard to recall what things were like. So we try to focus on the uplifting moments as opposed to the challenges. There are moments of selflessness and kindness that I've experienced. I've had at-risk family members mail me half-full boxes of N95s that they found in their basement from painting projects several years ago. A friend stopped by with bleach because he couldn't find any in the stores, Gatorade, and a few rows of toilet paper, as well as some signs that were handmade by her young neighbor. We received texts and phone calls and letters to many of us showing our support and offering the occasional meal and the much needed words of encouragement. I would say probably the highlights of these uplifting moments over the last few months was the Supreme Court decision on Title VII and the impact that decision would have on LGBTQ employees throughout the nation. That has probably been the biggest highlight over the last few months, especially knowing the tireless work that organizations such as GLAMA have put in to help make that decision possible. There's some days when we're at work and my coworkers and I look at each other and we ask out loud, rhetorically, how much longer do you think this will be? How much longer do you think that we'll have to wear PPE constantly during our shift? When will there be a vaccine available for mass distribution? Of course, we don't know the answer. So the musing stops and we get back to work, because usually around that time you hear the siren of another ambulance pulling into the ambulance bay. And at some point, I make a mental note that I really need to start being proactive about self-care. This is a marathon, not a sprint. And then the thought fades away and we go back to work, because we took an oath to first do no harm and we expectantly wait to see what tomorrow brings.